Okay, take your time if you're still getting settled. We're going to go ahead and start. This is one of our favorite parts of the day and our concluding session, which is lunch, and also the Ask the Expert opportunity. So please don't be shy. If you have a question, I can almost promise that someone else in the room wonders the same thing, and you don't have to write your name or anything. You can just send it anonymously up to the front. And so we'll kind of go ahead and answer the questions that we have so far. It looks like we have 2 or 3 questions for Dr. Dorsey, so we'll let you start with answering one of them.
Thank you very much. Delighted to be with all of you. Thank you for all the kind words. If you didn't get a copy of our book, Ending Parkinson's, we still have more copies. We're delighted to give you them. And if you haven't ordered our new book, please do so. One question is, why does it feel like why does it feel like you are a singular environmental medical voice in the Parkinson's community? Where are the other scientists to help support these facts? I think we're absent without leave. I think it's a great shortcoming of our profession that we're unaware of these chemicals. I trained at top institutions like Michael, like Chris, like Irene, and we weren't taught this. We were taught, if anything, to be deeply skeptical of environmental causes of diseases. I still remember the occupational health lecture. You guys probably had the same one. We were told like carpal tunnel syndrome from people using jackhammers. I think there's also reasons why we're ignorant, because I think companies don't want messages to get out and suppress it. They also attack scientists, some of my peers. I've gotten emails from them being attacked just this past week. So it's not a popular position to take. I also think we live in an era that's defined by genetics. So one of the great scientific advances of the last 50 years is the identification of DNA, and that's led to huge investments in genetics, and those investments have paid huge dividends. A lot of the diseases that we care for, Huntington's disease, spinal cerebellar ataxias, all these rare diseases have huge genetic components to it. But if you think about it, genetics can't explain why people get common diseases. Things that are really common, heart disease, lung cancer, breast cancer, prostate cancer, emphysema, these can't be due to genetics, because if they were due to genetics, they would have already been screened out before the present time. So I think, one, we live in a genetics era that's provided advances, but genetics as a whole only explains 20 to 30% of health. We're not taught it. I think some of that ignorance is intentional, and then people get attacked for speaking about these causes. So I think those are all reasons why, and we all suffer because of it.
Thank you. Dr. Burke, can you share the question?
Sure. Okay, so this question is, are the potential long-term effects of DBS that were mentioned attributed to their surgery or to long-term progression? And so with side effects from DBS, typically what we'll see is any complications that happen in the OR, in the surgery, we know kind of pretty soon when you come out of the operating room. And those ones can be attributed directly to the surgery. With things like dysarthria or some imbalance problems, those are a little bit harder to tease out. What we often will do is monitor those over time and see if changing your stimulation parameters affects those symptoms at all, to say whether or not this is a result of the stimulation from DBS or is this progression of the Parkinson's disease itself. So it's a little bit of a both answer to that question, but things that we kind of have ways of teasing out in the clinic with you and watching over time.
Yeah, no, I completely agree, and I think that it's important to remember that when most of the investment when you have deep brain stimulation is upfront. One of the advantages of the stimulation over other techniques is that if you turn off the device, the symptoms induced by the electricity will go away. So initially there was a a lot of interest in seeing if DBS will have a direct effect on slowing down disease progression. We don't think that that's the case, but certainly the long-term benefits of DBS change some of the expected trajectory of the progression of motor symptoms, as DBS continues to be very effective in treating slowness, dyskinesia, and tremor even long-term. But some of the other symptoms that occur with the disease may not be treated, and some of the problems that you mentioned, like speech and balance and problems with gait, are more likely and most of the time related to progression of the disease. I will do this next question. It's also a question about neuromodulation and for the treatment of headaches. And is this something that could be used specifically focusing on orthostatic hypotension? What I would say about this is that neuromodulation per se, not necessarily deep brain stimulation, has been tested in patients with headache, in patients that have headaches, not necessarily in Parkinson's. And there are a few techniques looking at stimulating the nerves to try to help with refractory headaches. Deep brain stimulation per se has been tested also in patients with headaches, and that has not been as successful as you would expect. And when you focus on orthostatic hypotension, there's no, as we know, there is no clear direct effect of deep brain stimulation on the autonomic symptoms, including the orthostatic hypotension. It's not uncommon to have improvement in orthostatic hypotension if that was caused by medications before surgery. Because a lot of the things that we can do after surgery rely on potentially making changes on your medications that we couldn't do before surgery, because now the surgery is really helping to manage those symptoms. So a common example is that if you are having low blood pressure because of certain medications for Parkinson's, after surgery, we may be able to get you off of that medication. You don't need it anymore because now surgery is controlling your tremor. So indirectly, we could see effects on some of these symptoms, including orthostatic hypotension.
All right, so this is a really good example. You guys asked the great questions and some of the tough questions, actually. So the question I received is there a trial going on to introduce a drug into the brain to change some of the neurons into dopamine-producing neurons? So highly technical question. I'm going to answer a couple different ways. Number one, I'd say, no, there's no pill that we have currently that can tell your other brain cells that don't produce dopamine to produce more dopamine yet. There are a couple other ways that people actually are, there's ongoing research here to work on this. So one way was to introduce those cells via what's called stem cell or even embryonic stem cell or other ways to produce stem cells to put them back into the brain. So there are actually a lot of efforts on that front. Probably many of you have heard stem cells have proposed to do anything, fix anything, except for the kitchen sink, basically. So all disorders have been looked at, particularly neurodegenerative disorders, to find ways to. Stem cells basically are those things that have this potential to become any kind of cell, okay? And there are different sources of them. So embryonic was one of those. Of course, there are ethical issues with collecting those. Plus, embryonic stem cells from other people might induce some sort of, we call immune reactions, host reactions, and you have to use some immunosuppression for that. But there are different kinds of stem cells nowadays, even ones that you can derive from your own body. We call those autologous stem cells. You can get them from the fat or other even stem cells or other areas of the body as well. And those are your own stem cells, and those basically you don't have reactions to. And they can also be introduced into the body too. However, there are a lot of challenges for this. So I want to really emphasize the challenges issues. You can't just put stem cells into the body and expect them just to become the brain. I kind of liken it a little bit to basically taking gas and throwing it on your engine. It's not going to go in the right place. You got to put gas into the gas tank to get it to the right spot. Same thing kind of like with a computer. If you put a part, you can't just throw it in the computer box and hope that it's actually going to find the right place for that part to actually make the computer go. So the brain is a really complicated organ. You're born with it. It's developed over time. Making those complicated connections that allow you to behave appropriately takes a lifetime. And to regenerate those is a huge, huge challenge for us. We do hope that stem cells can eventually get there, but there's a long way for us to go. There are other benefits from stem cells. People are doing a lot of research. Stem cells may produce, we call humors or hormones that might actually help some of those brain cells survive. So there are other effects that might be helpful in the brain, potentially, or even other organs, actually. So other things that stem cells might be doing, but we're still at the research stage with regards to stem cells. There's a lot of new research ongoing with stem cells. We can actually engineer stem cells. We can tell them these days, so it's really neat. We can tell them to actually become specific neurons, and we can even tell them not to be just neurons, but to be, we call those dopamine-producing neurons. And then we may be able to put those back into brain, but putting them back in the brain requires some surgical therapy to do that. So it's a complicated process. It's definitely not a pill yet. So another half of this, or another aim of this kind of question actually is, can we tell your brain cells to become, so there you have brain cells, can we tell them to produce dopamine? And so another way that researchers have been looking at, and this has actually been done over a number of years, and even currently, is to genetically change the genetics of a cell, okay, by introducing some genetic information. And we have techniques like that. Ways to do that is actually by using a virus, so viruses that have been engineered not to cause disease, like the cold virus, but they don't cause the cold. And you can use those viruses to introduce genes to regulate the way a cell functions. And you can actually, there have been, researchers have developed different ways to introduce genes to produce dopamine, so some of the enzymatic pathways that either make dopamine produce more, as well as maybe reduce the breakdown of dopamine, so basically like stopping up the drain, so dopamine can't be degraded. And so people actually have done this so well, they've even introduced 3 different genes in a virus into the brain and show that it actually does have some potential for working. But there's a lot of research, okay, that needs to be done. So I do tell folks, we are sort of at this verge of getting there, but there's a lot of more research. There's so much potential with different ways to introduce genes, stem cells. You can go out there in the public and get stem cells. You can buy them. There are a lot of people out there, even in Florida, there are places where you can get them. Just understand these are still research-based. All of these therapies are not FDA approved yet. They may have FDA approval to do the procedure, but not necessarily approval saying that this treatment is going to work for you. So often we all warn folks not to be taken. If you're going to do a trial, that you should be compensated. There are risks to all these therapies. So just be careful going into, ask us about them. We can discuss the pros and cons for them. But we don't want you to be taken if you're going to be part of a trial. And there actually are some stem cell trials, and even some of these new types of stem cells that are coming. Our center is actually looking into participating in one of those trials. A couple of them actually. A couple of them. And they are very promising. So we're going back to stem cells and looking at them more carefully. They were done many years ago with great potential, but people did have side effects from some of these therapies like dyskinesias. And now we think we have the engineering techniques, the biochemical techniques to actually make these cells, totally fine-tune them and make them much better. So long story, but a lot of potentials there.
Thank you. Dr. Oken, did you have any more comments about that? I know we had 2 or 3 questions about stem cells.
Yeah, so there were a couple of questions here on stem cells to treat and reverse Parkinson's and stem cells and Parkinson disease. And so building on what Dr. McFarland so eloquently summarized, I will just add a few things. First of all, raise your hand. Anybody like podcasts in here? Anybody listen to podcasts? You podcast listener? So if you're a podcast listener, there's a podcaster named Laura Beal who has a podcast. This is kind of dark, okay, called Dr. Death. But it wasn't that podcast that she's an investigative reporter. Her father had Parkinson's disease and was interested in stem cells. And so she actually did a podcast called Bad Batch. And so BAD, batch, BATCH. And she actually went around as an investigative reporter and asked all the questions that you and I would ask about all of these places that are all over the world, all over the state of Florida, all over every province, every region, every prefecture, in every country, people offering these stem cells and what it all means. And sort of at the end of that, Nick, she kind of comes to this conclusion that, that this is more of a for-profit industry that isn't necessarily safe, and that there's also a whole bunch of people that can't afford it and pay a lot of money for these things. And they thought, well, it can't hurt anything. And then she talks about a lot of the cases where actually people did get hurt and go blind and have tumors and things like that. And so we definitely, not to be dark on the stem cell issue, just be a little bit careful and make sure it's a research study. The Parkinson's Foundation does have a set of guidelines that if you're considering stem cells that you should always be thinking about and thinking through to make sure that you stay safe. Having said that, in the next book that we were writing, we got the opportunity to interview experts from all over the world. And so we did several dozen interviews, and we actually spoke to a lot of the regeneration. This is called regenerative medicine researchers in and out of the areas of Parkinson disease, things like CRISPR gene editing, stem cell therapies, next generation stem cells, like what Nick was alluding to. And one of the things that I found very interesting was that a lot of the regeneration researchers have begun to pivot and say, well, we know Parkinson is caused by more than just dopamine, so now if we replace the dopamine, it hasn't cured the disease. So I think that was the biggest, sort of epiphany moment for a lot of people in the last 2 decades was, oh, let's just replace the dopamine with stem cells and Parkinson will go away. It didn't happen, and we can do it, as Nick said. But what researchers have said, well, how about if we adjust our thinking a little bit and we look at a specific symptom that some of the therapies are not addressing. And so one of those symptoms has been memory and thinking dysfunction. And so a lot of the regenerative researchers are now looking at specific areas within the brain to say, well, maybe if we go after, and there's an area called the nucleus basalis of Meinert is like one, and it's connected. It has a whole bunch of different connections, and they thought, well, maybe if we start to use some of these stem cells in some of these areas, we could stamp out a symptom that is really important to people, and that's memory and thinking. And so I think you're going to see some nuance and some changes about how we're thinking about stem cells. And the last point that we learned from interviewing folks was that stem cells can be put into a dish, and that sounds like old-fashioned, but actually now people are growing what are called mini brains in a dish. They're called organoids, and many people refer to them as mini brains in a dish. And you can put a bunch of these mini brains together, and they may be able to recapitulate or look like what happens in the human form better than we thought before. And so these stem cells that Nick was talking about are actually proving to be much more valuable right now to researchers trying to answer the why questions. Why are we getting Parkinson? What's going on that's causing it? And so just a way to kind of rethink and reframe.
Thank you. Okay, the next question is orthostatic hypotension common? And what's the best treatment? So orthostatic hypotension refers to a problem where when a person gets up suddenly, either from laying to sitting or standing, within a minute or so, they get kind of dizzy or woozy or lightheaded. And that has to do with sudden drops in their blood pressure. And this is very common in Parkinson's, and sometimes it's a secret cause of falling. If you notice you always fall in the first few minutes after getting up, this could be part of the problem. Very common in Parkinson's, especially the longer a person has Parkinson's. So the best treatment, first of all, number 1, 2, and 3 is to make sure you're drinking more water, hydrating. And I think of it as like if you ever tried to water a garden with a hose and didn't turn up the hose enough, the water wouldn't get through to the other end. So we have to have enough in the pipes to get it where it needs to go. So water. The next thing is you can be a little more liberal with your salt intake. So most doctors tell you no salt, low salt, but this is a problem that actually does better with a little more salt in the diet because it keeps the fluid in the blood vessels. And the other thing is we have to look at your medicine list because some medicines are good at aggravating this, and sometimes we can move things around in a way that lowers the chance of this problem. And finally, we have actually one more thing. There are compressive stockings you can wear or an abdominal binder, which give a little bit of a squeeze that help this circulation problem. Before you get up out of bed in the morning, it's a good idea to sit for a minute before you stand. And you can even squeeze your knees to your chest a little bit, and that can help this problem. Finally, there are 4 medicines that we use to help this problem. Their names are midodrine, fludrocortisone, pyridostigmine, and droxidopa. But there are 4 medicines we can prescribe that work in slightly different ways to reduce this problem. So it's very treatable and very important problem.
Sure. Do you find, is there a correlation between paraquat and TCE exposure and young onset Parkinsonism and death? So we showed you that 80% of people who have young onset Parkinson's below age of 50 have nothing to do with genes. Even if your onset is below the age of 30, 70% have nothing to do with genes. So I think it stands to reason that environmental chemicals, including paraquat and TCE, are linked to it. You know, the most famous person with young onset Parkinson's is Michael J. Fox. And so this is public information. He was part of a cluster of individuals on one of his early TV shows before Family Ties, where 4 of the 100 people working on that TV show developed Parkinson's disease, suggesting an environmental exposure. He recently told Jane Pauley that he thinks he got Parkinson's from exposure to some kind of chemical. And then the other side is he's lived a very long life. He's over 30 years into his Parkinson's. So although Parkinson's has a moderate increase in mortality, people can live very long lives. You can star in TV shows. You can get a PhD. You can serve in Congress. You can serve in the Senate. You can be the head of the Catholic Church. You can walk in space. You can do lots of things, and people with Parkinson's have done all of those things. So as you all know, Parkinson's is far from a death sentence. People can live highly productive lives with this disease, but fundamentally we're talking about a disease that is preventable and that people can live lives free of this disease, and I can't think of a better gift.
Okay, I'm going to try to answer 2 here because they, I think, are on the more quicker side. One question was, how do we recruit movement disorder specialists to our area? So this is a challenging one. I think this is something that Parkinson's disease patients around the country sort of struggle with. For the most part, movement disorder specialists will tend to cluster at academic centers. So if you don't have a large academic center, finding a movement disorder specialist in private practice can be a little bit challenging. There's nothing specific that I could mention that you could do to recruit a movement disorder specialist to the area, with the exception of potentially talking to the local hospital and trying to get them to realize the importance of having a movement disorder specialist. That might help them to recruit, but even if they had an open recruitment, it's difficult to get to find movement disorders neurologists because there just aren't that many of us. One other question. Someone had written in the night around 3 a.m. they are experiencing unrestful sleep and then nightmare starts, and they take an extended dopamine, extended release Cinemet when they go to sleep. Any ideas would be appreciated. So obviously sleep issues are significant and part of the non-motor issues of Parkinson's disease. You would need to get a full evaluation to get a specific answer, but one thing that people could consider doing in this situation, if they're finding that around 3 o'clock in the morning they're having a sudden waking up. They may be acting out their dreams. So REM sleep behavior disorder is common in Parkinson's disease. Sometimes it can even precede the motor symptoms of the disease. And so melatonin can sometimes be helpful at bedtime. I usually recommend at least 6 milligrams, and that can sometimes control some of the movements that would wake someone up during sleep.
All right. I have a question regarding my talk. It says, are Crexont and Vyalev available at UF Health? So Crexont is the newly approved drug that I mentioned, the combination of carbidopa, levodopa, extended release, and then Vyalev is the subcutaneous infusion pump for carbidopa, levodopa. So the short answer is yes, those therapies are available at UF. And the long answer is that there are some conditions. So for the Crexont, like I said, it's new, so we're still kind of trying to work out what steps the insurance companies want us to take before they're willing to cover this medication, and what kinds of resources we have available if the insurance is hesitant to cover them. So we're still kind of working out exactly how that works for people on different insurances, but I will say that we have several people in our clinic who have started it, and some people really like it. So that one is available, but as I mentioned in my presentation, usually that's something that we'll kind of progress to given the insurance constraints after people have given a good trial of some of the immediate release, Cinemet, or the controlled release, maybe a couple other different medication options too. And then regarding the Vyalev, we're still kind of working out how that process is going to look in our clinic, but we've been trying to get a couple people started on that. As I mentioned in my talk as well, there are a few requirements and kind of qualifications that people have to meet to qualify for this under insurance plans. One of them is you have to be 65 years of age or 63 years of age or younger and be on a commercial insurance that is not a Medicare insurance. And that's going to be the case at least for a few more months, but they're working on getting Medicare coverage as well, and that might open up the age range that's available to people. These people need to respond to oral carbidopa, levodopa, so have some symptom improvement. And they have to have at least 2.5 hours of off time per day to qualify for that. So there's a few conditions, but the short answer is we do offer them at UF.
And in case anyone doesn't know what's Vyalev, that's carbidopa, levodopa subcutaneous infusion. So that's the pump that goes under the skin.
All right, I have someone asking, does Parkinson's continue to be more prevalent in men compared to women? Are there any changes? And by the numbers, yes, it's more common in men in the United States. But just last night, Dr. Dorsey was telling us that depending on who you ask, in different countries it's more common. For example, in Japan it's more common in women. In some Latin American countries it's more common in women, some of them more common in men. So if you average it out or over the years, it's probably about the same prevalence, both in men and women. The difference between men and women, is, as I was telling you a few minutes ago, was that we have increasingly recognized that Parkinson's may present slightly different in women, especially when it starts. Women more often present with focal dystonia, or things are not the tremor, the stiffness, the slowness that is traditional. So over the years, we've been increasingly recognizing that more as Parkinson's. So it used to take longer for us to figure it out that women started to have Parkinson's, but now it's starting to change. A good analogy for this is when heart attacks in the 80s and 90s, that we used to think that almost only men had them. But then we figured out that in women, more commonly have atypical presentations where they will have like stomach pain rather than chest pain. And we used to think that was indigestion, but no, it's just an atypical form of a heart attack. So over the years, we've been able to recognize it more. But in reality, it averages out to about the same.
So we have 3 more questions. I also want to thank everyone who's watching virtually. And some of these questions actually came from our virtual audience at home watching on Zoom. So this question is there a best time to take medication? What if you're told to take it twice a day, for instance? So an excellent and important question on timing of medication. Definitely something you want to work out with your healthcare team because it's very different one person to the next. The kind of general influences of the best timing have to do with spreading it appropriately across your day so that you have continuous control of your symptoms. The longer we have Parkinson's disease, there are more changes in our brain so that our brain is less able to hang on to that medicine and benefit from it for more hours. And we need to take it more frequently and sometimes at higher dose the longer we have it. There are some factors that can be important. For instance, when do you wake up? When do you go to bed? When do you eat your meals? And what are your activities? If you love to golf, which is important to probably several people in the room, sometimes we want to make sure that you're at your best benefit during that time that you want to be active. Sometimes we'll even fine-tune a certain dose to be a little higher because we know you have activities. The other thing has to do with meals. If your Parkinson's symptoms are mild and you haven't had it for very long, we might tell you to take your medicine with food because you'll remember to take it and it helps you not get an upset stomach. But if your symptoms are not easy to control or you've had it a long time, sometimes we want to time the medicine away from the meals because for some people, the food, absorbing of the food interferes with absorbing of the medicine, and they might feel like their food makes their medicine not work as well. So there are a lot of different factors, and how you do when you come back and tell us, hey, I feel great, but then 30 minutes before my next dose, I start to feel bad again, that would change the timing that we might tell you to take it. So it's different for each person. If you're only taking it twice a day, which is probably unusual, you're probably going to take one in the very beginning when you wake up and one maybe around dinner time if you're only doing it twice a day, but that's unusual. So make sure you talk with your doctor or healthcare provider to sort of sort that out.
All right, and then we have another question about DBS here saying, what considerations and issues of going from unilateral DBS to bilateral DBS? And so this is a really great question, and a lot of it will depend kind of on the center that you have your DBS surgery performed at, because where we are, we typically like to do a staged surgery. So we'll start with one side of the body and then we'll go to the other side after some time and after we've optimized the settings for the first side. With other centers, sometimes they'll place both of the sides at the same time. And so when we are looking at side effects, the things that we see an increase in when we're going from one side to the other to having both is that we can see increases in dysarthria, we can see increases in balance issues. Yep, and that's the feelings of kind of like talking almost like you're drunk, a little bit of slowed speech, clumsy speech, things like that. Those are the symptoms that we typically see a little bit of an increase in when we go from unilateral to bilateral. And a lot of times we can adjust the stimulation to try to get away from some of those symptoms, but we definitely will notice that can be something that pops up.
Okay, and the final question is for Dr. Dorsey.
Thank you very much. So the question asked about inconsistencies between data on environmental exposures and Parkinson's. So I showed you a map that showed areas of the country with high rates of air pollution had high rates of Parkinson's, and low rates of air pollution, low rates of Parkinson's. But there are obviously some inconsistencies. And it really shows how difficult these studies are to be done. So, for example, many people, the exposure that might be relevant is when you were young. So many of you shared with me your stories. Many of your exposures when you were 18, 19 years old. Some of you had exposures with children. If we mapped you all to Florida and you had Parkinson's or not have Parkinson's, the relevant exposure may have nothing to do with the environment of Florida. It may have been the environment that you had when you grew up in Ohio or Turkey or wherever you grew up. I'll just point out, you saw some great data especially from the fellows that were from randomized controlled trials. And they showed randomized controlled trials for focused ultrasound, for DBS. And those studies are all controlled. And so that's why you get really good answers as to whether DBS works or doesn't work, whether focused ultrasound works or doesn't work, why a certain formulation of levodopa works or doesn't work, because you can answer that question in a controlled study, and you can, from that, reach a conclusion about causation. For environmental, we don't randomize people to farm with paraquat or not farm with paraquat, follow them for 50 years, and then see who develops Parkinson's disease, right? Not ethical, not feasible, be really costly to do so. So like really one of the great studies is this Camp Lejeune study. So I'll show just some difficulties with the Camp Lejeune study. So Dr. Hess here was actually served at Camp Lejeune after the chemical was cleaned up, but they followed these individuals from the 1970s and then looked at Parkinson's 30 to 40 years later. So one, you have to find a cohort. Then you have to find a comparison group. So they found a comparison group of people who served at Camp Pendleton and followed them forward. Well, a couple things. One, Camp Pendleton was also contaminated with TCE, but less so than Camp Lejeune. So that biases your results to be understated, right? Second, if someone from Camp Lejeune died of cancer before they got Parkinson's disease, they would never be counted as getting Parkinson's disease. Next, if they were misdiagnosed, they didn't get their diagnosis correctly, and many of you have been misdiagnosed with your Parkinson's disease or had a delay in your diagnosis, that understates the results of the disease. Third, these were all based on claims data. They didn't actually examine the individual, so they relied on claims. You know, when we fill out the form, when you get checked out, we circle you have Parkinson's disease. Well, if we circle the wrong thing, and sometimes we make the wrong diagnosis, that will also biases you to understating the results. So even in a study done by the best epidemiologists in Parkinson's in the world with a well-defined cohort, you still have almost everything stacked against finding a relationship. Almost everything is stacked against you determining that this chemical causes the disease. So when you see a 70% increased risk or a 500% increased risk, you need to sit up, pay attention, because that's probably understating what the true effect is. And so many of these things we just miss because it's really, 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 really difficult to do so. So I'll demonstrate. How many people now think that they know what might have caused their Parkinson's disease? How many people think had some Parkinson's disease? Right? So we have about 10 hands. When we started this thing this morning, we had 2 hands. So just from the span of just one day's worth of thing, we've identified causes of the disease. But you guys are all hyper-educated. You're seeing Dr. Oak and you're seeing all these great physicians here, and you didn't know what was causing your Parkinson's, and now you know. So just think about how difficult it is, and then pay really, 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 really close attention when they find a link between an environmental exposure and a disease, especially when that link makes sense as to why it might be causing the disease.
So we just had 3 more questions brought up to us from the virtual audience. I think you'll find them interesting.
So it's a question, not so much a question as 2 words with a question mark: vibration gloves. So the story of vibration in Parkinson is one that's been around here for a few hundred years. There was a very famous neurologist called Professor Charcot who practiced in a women's hospital called the Salpêtrière in Paris, and people would roll up in their carriages to see the professor from all over the world. And when they got out of the carriages, he would note that many of them felt like their Parkinson's symptoms had gotten better, potentially from the shaking of the carriage ride over the roads which were not paved. And so, he built vibration helmets, and there's been a whole group of folks for a long time interested in could vibration be a potential treatment for Parkinson's. The answers to this have been mixed, and there probably are some mild benefits from vibration, so there's probably something to it. There's a researcher at Stanford called Peter Tass, who is a physiology type of researcher who's been interested in the oscillations in the brain, and how when you apply vibrations, it changes the oscillations in the brain. And he had some gloves that were, some people were on the Today Show showing they're wearing the gloves and felt like the gloves improved their Parkinson disease. Getting back to Dr. Dorsey's comments, none of those studies were controlled. There were no controls on the studies, and then there have been other devices like Dr. Hess and Dr. Helmuth and Dr. Bloom and colleagues in the Netherlands just tested one of those vibration devices and published on it, and it did not show in a controlled study across the group, across the cohort, that it improved folks. They're usually not harmful. as treatments. They're not particularly robust, but there might be something mildly to these things. But when you see them, be a little bit cautious. I remember getting a letter from somebody who was on one of the TV shows that was interviewed about one of these types of therapies that's being asked about, and them saying, oh, I read your blog, and then after I read the blog, I realized I was so excited to be on the X show, which was, a nationally syndicated show, that maybe I overestimated to the people how great this therapy was, and I realized it probably wasn't as good as I thought it was. And so I think waiting for good studies is an important thing. In this case, most of these things aren't going to hurt you. They might hurt your pocketbook, but unlike stem cells, we now think some of those therapies, if you try them, could actually hurt you. So I think we always have to keep an open mind, also think about where the evidence is. In vibration, probably some mild benefits, or maybe some people that benefit from it more than others, and probably safe, but not as maybe robust as we'd like. Too much talk for a two-word question, huh?
Quick question.
This is another quick question that got asked with focused ultrasound or DBS okay for pacemakers. And so DBS is perfectly fine for pacemakers. Focused ultrasound, it depends only if their pacemaker is MRI approved. If your pacemaker is MRI approved, then focused ultrasound is okay. But because you have to be in the MRI, it's gotta work in the MRI.
So we get the last question is a three-part question. So I'm going to do this with my big brother Michael. Some questions about global. So what other countries are leading or at the forefront of Parkinson's disease research and treatment? You interviewed lots of experts for our book from around the world. What'd you find?
Well, I was actually really impressed with the quality of scientists across the globe that are really digging in on this. And we spoke to people on every continent except for Antarctica, and it was a little too cold for us to go there. And we definitely saw leading researchers across Europe, multiple countries across Europe, Britain, the Netherlands, Germany, Austria, Italy, some really nice research coming out of those areas. Some nice research coming all the way across out of Australia. But also lots of really interesting things happening in Malaysia, happening in Indonesia. A lot of researchers now doing good work in China. So I, was very impressed, and then a whole bunch of people in South America, and then you see a whole bunch of our fellows here up with us now that are going to be graduating, and we put over 100 fellows out that are all over the world, and so I think there's quality people, and we have had folks say to us, hey, I want to go on vacation with my Parkinson, where should I go? And I often say, well, we probably have a fellow there in one of those countries in case you get into trouble and need some medications, which happens every once in a while.
And then, Michael, are there any other countries that are ahead of the U.S. in terms of collaborative Parkinson's disease treatment? Are these countries that have more Parkinson's specialists? Maybe you'll say a word about our good friend and colleague, Dr. Bas Bloom.
Yeah, so per capita, Parkinson specialists are like an endangered species. If you know that the endangered species list, if they had one for doctors, Parkinson specialists would be on that list. Train about 40 to 50 a year within the North American, regions, and then across Europe and other areas, people sort of tend to go into these areas, but a lot of times there aren't specific training programs beyond things like neurology, psychiatry, geriatric medicine, and so it's a real problem given the challenges that were outlined by Dr. Dorsey in terms of the growth rates that we're not investing in these things. We certainly have invested in tons of cardiologists all over the world, and you've seen that with all the different studies that have been done on heart disease and everything, and it's made a difference. In Framingham study Ray and I were talking about yesterday, and all the things that we've learned about high blood pressure and stroke and heart attacks. But what really is focusing our communities now, the focus should be on the growth of neurodegenerative disease. one of the countries that does stand out is we have a good friend named Boston Bloom, who was a co-author on the Ending Parkinson Disease book. They do outstanding care throughout the Netherlands. We often hear people say, I'd like to take my vacation to the Netherlands because I know they have Parkinson specialists in every one of their provinces. It's about 20 million people, so it's about the population of Florida, but in a different shape there, maybe with 2 or 3 more windmills than we have, and a little bit more dense across that. But they have put specialists and specialty teams across the entire area. Most countries are struggling, and so we're not alone. And the World Health Organization has put together a number of different panels. Even recently, we were part of the 6 or 8 action steps for Parkinson's disease.
And then the last question is, if you were a single 50-year-old individual with Parkinson's disease and could move to any other country, where would you go? So actually in our book, if you have means, we make you consider where you live and where you work. The health you have today is a reflection of your environment, not so much your current environment, but your past environment. That said, there's increasing evidence that, for example, air pollution is harmful for people with Parkinson's disease. And there have been studies in Los Angeles that have followed 70-year-old women who were cognitively normal, and women who lived in heavily polluted areas of Los Angeles had greater cognitive decline than women who lived in less polluted areas of Southern California. So I would give thought as to where I lived. I'd give a lot of thought to air pollution exposure. I'd give a lot of consideration to pesticide exposure. You know, there have been studies linking golf courses, for example, to proximity golf courses to Parkinson's disease, at least in case reports. We talk a lot about avoiding dry cleaners and the like. So I would give a lot of thought. Well water and testing your water, for example, I would give a lot of thought to my environment for your health today and your health tomorrow. And I would do that also for your children and your grandchildren, because their environment that they have right now might dictate whether they develop diseases like Parkinson's and Alzheimer's generations later.
So again, we thank Dr. Dorsey for coming to be with us today. We thank all of you for being here today, including our virtual friends that are watching us over the computer. If you have any thoughts about talks that you really loved or talks you'd like to hear next year, you can let me, Amanda, or any of us know, and we constantly try to incorporate what we hear from you. So thank you so much, and enjoy the rest of your day.